Hi everyone, welcome to this evening's webinar. My name is Banu and I am a client manager and a clinical case manager here at VET.CT. Before I introduce Pilar, our fantastic speaker, I'm going to take a few moments to tell you a little bit about VET.CT and how our services can help you, your teams and your patients. Pilar, thank you. VET.CT is a global company of over 200 specialists, and we are all here to help you whether you're in first opinion practice, university, specialist hospitals, or another clinical setting. The service we're most well known for is our radiology service, and we also offer specialist advice and education services. And what I would like to tell you more about this evening is our specialist advice service. We have over 50 specialists offering advice across 13 specialties. When you use the service, you'll receive summary written advice within 12 to 24 hours of submitting your request, and often it's sooner. We also offer phone calls and text chats in medicine, neurology, oncology, and orthopedics, which are available as bookable slots through the desktop or app. If your case needs advice from another specialty, we organise that for you at no additional cost. And we also provide unlimited follow-ups on the cases so you can share updates and have ongoing advice and support. Our aim is to provide quality, practical advice and support you managing the patient in your practice, and we view this as collaborative care. We also have an incredible support team who are all clinically trained and are available 24/7. You can ask them for help and support anytime, and you can also communicate directly with our team of specialists if you have any questions about your case. Can I have the next slide, please? If you'd like to know more about our specialist case advice, you can scan the QR code on the screen, or you can reach out to our client success team to find out more. Simply email us to arrange a no obligation discovery call at a time that suits you. Perfect. So just a little bit about the webinar tonight. It is being recorded and we will share the link with you in the coming days so that you can replay any part of the webinar or share it with colleagues. The talk will be approximately 30 minutes and then we'll have a Q&A session. So if you'd like to submit any questions, either as they come up during the talk or at the end, please do so using the Q&A option on Zoom. Please note that chat is not available on webinars on Zoom. I'll collate the questions and ask them to Pilar on your behalf. I would just ask, sometimes we don't get enough time to answer all the questions. So if you're happy for us to get back to you after the webinar, please post the questions without being anonymous, if that makes sense, if you're happy to do that. So I'm delighted to introduce Pilar Lafuente to you tonight. She's one of our experienced orthopedic surgeons, and I will pass you on to her. Thanks so much, Pilar.
Thank you very much, Banu, and thank you very much, everyone, for being here. And those who will be seeing this webinar later on, I hope that it's helpful to you. So today, this is the second part of this webinar series. A few weeks ago, I did the forelimb lameness evaluation and how to localize the source of lameness. And today, we are going to do hind limb lameness, so problems in the hind limbs. So the learning objectives of this session, so I want you to recognize and develop a systematic approach to the orthopedic examination of the hind limbs. I would like you to be able to recognize and interpret additional clinical signs related to hind limb lameness, and also refine these localization skills so that we are able to localize where the lameness is coming from. So here, for example, we have a dog that shows a hind limb lameness. You can see that the dog is lame on the left hind leg. There is a shorter stance phase, so the leg is on the floor for a shorter time, and then puts the right hind faster. Usually there is a combination of a head bob as well. So generally the head goes down in this case when the lame leg or the painful leg is on the floor, but with the hind limbs it's a little bit more difficult. So this will be an example of hind limb lameness. We will see a few videos. This is another example of a dog with a hind limb lameness. In this case, the lameness is different. We will see what this is which condition this is. And sometimes it's very useful to use a slow motion recording so we can see the movement of the legs a little bit better, because sometimes the movement is so fast that we cannot really see with our naked eye. So you can see that I use a slow motion. I recorded the gait analysis or the movement of the dog, and then I play it in slow motion. But we will see what this is, because this is very characteristic lameness. So I'm going to follow a little bit the schedule that I used last time. So in order to be able to diagnose what the problem is in the hind limb of a dog, we need a detailed history of what's going on, for how long, any traumatic event, or any other systemic conditions that the dog may have that could be related to the lameness. The signalment is going to be also helpful to have differential diagnostic list. Also, gait evaluation is essential, and we can do it with subjective techniques or objective techniques that I explained last time. Today, we are going to focus on subjective evaluation, which is gait analysis, visual observation of the lameness. Then a general physical examination is always recommended, just to know how the dog is, if there is any other systemic conditions that could be related to the orthopedic problem. Orthopedic examination is essential, obviously, to be able to know, at least to localize where the problem is in the hind limbs in this case. Neurological evaluation, depending on our degree of suspicion of an orthopedic versus a neurological evaluation. And then with all this information, we will establish a differential diagnosis list, and then we will start doing some diagnostics until we reach a diagnosis. So this is how it works to reach a diagnosis. But today we are going to focus on gait evaluation for hind limb lameness and the orthopedic examination. So the gait evaluation is essential because it's going to allow us to determine which limb or limbs are affected. Most of the time, the owners, the clients are correct when they say the dog is lame on the right hind, but sometimes they may miss lameness, especially with bilateral lameness. Also, the type of lameness, if it's weight-bearing, non-weight-bearing, the severity, all that is going to give us some clues. And you will see that in some cases, just by looking at the lameness, we can pretty much make a diagnosis. It's not all the time, but in some occasions we can. So we can use a subjective method, so visual observation, which is readily available for us, or objective methods like a pressure mat, for example. That will be an objective, a kinetic technique. So today we are going to focus on visual observation. Generally, we check, the movement of the different parts of the limbs, the joints, the segments, also the times of the limbs touching the floor, and also during the aerial phase during the swing phase of the gait. Also, how quickly the movement or how quick the movement of the limbs are. And generally, we do this visual observation before we start doing any general or orthopedic examination. So, for example, we have this dog. We can do this visual observation from the side. Generally, we do it like I showed you before, with the dog coming towards us and going away from us. But especially in very subtle lameness, like in this dog, it's not very obvious, the lameness. Looking at the dog from the sides is also useful because you can see how much extension and reach the forelimbs and the hind limbs do during walking. And generally, we do this visual observation at walk and at trot. And also with subtle lamenesses, we, after walking the dogs in a straight line, we also make them walk in a circle, which can exacerbate the lameness or can make it more obvious for us to see. So that can be also helpful. So what do we see when we have a unilateral lameness? Generally, either they keep the leg elevated, so for example, an intermittent or non-weight-bearing lameness, or generally the stance phase may be shorter, as I showed you before, because it's painful for them. So when they put the leg down, they bring the opposite limb, the contralateral limb, faster. They may show also some circumduction or some external rotation of the limb. And the head bob, as I told you before, with the forelimbs is quite obvious. With the hind limbs, it may not be that obvious. But generally, when the painful limb is on the floor, the head will go down because they are trying to move the weight towards the forelimbs because that hind limb is painful. So for example, here we have another dog. I don't know if you can see, the dog is lame on the right hind. So the dog is smaller, so the movement of the legs is a little bit faster, but you can see that the amount of time that that right hind leg is on the floor is shorter. The dog tends to move the left hind faster because that right is painful. And then we have some very typical types of lameness. This is the dog that I showed you before. The dog was lame on the left hind. You can see it quite obvious. There is a bit of abduction, external rotation of the left hind, and also a shorter stance phase. The dog tends to put the right hind faster because the left is painful. So this is a weight-bearing lameness. I would say the degree of severity, maybe a 5 out of 10 lameness. This is a little bit subjective, but around that. This is a typical lameness of a dog with a cranial cruciate ligament disease. Generally, they show a weight-bearing lameness. Obviously, it can have other sources, but at least it's typical to see this type of lameness. For example, if we see this other dog, it's very obvious that the dog has an intermittent non-weight-bearing lameness on the left hind. Do you see? This is a skipping lameness. At times, the dog doesn't put the leg down at all, and it keeps it up just for a stride. So see, another time. So this is very typical, this type of lameness with patellar luxation, especially medial patellar luxation. So I'm not saying that it's pathognomonic, but it should be, high in our list. Obviously, the orthopedic examination is going to be essential. Other types of lameness, for example, this is a large breed dog. This is a dog with lateral patellar luxation, which even in large breed dogs, medial patellar luxation is more common than lateral patellar luxation. But if we have a dog with lateral patellar luxation, it will be more likely to be in a large breed dog, if that makes sense. So if this dog had a lateral patellar luxation, the lameness is different. In this case, the patella is laterally luxated, so the leg is kind of like adducted and externally rotated, and it's a weight-bearing lameness, but it's quite obvious that the dog is lame. This is the dog as before, that I showed you before. So this is a very characteristic lameness or pattern, gait pattern of a condition. And I want you to see the movement of the tarsus. So the tarsus does this external movement with internal, kind of like internal rotation of the paw, and the tarsus is moved laterally in both hind limbs. It's more obvious on the right, and also we can see that during the swing phase, it's kind of like stops suddenly, and then the dog puts the leg down. This is the typical lameness of a dog with gracilis contracture. The gracilis contracture causes this sudden movement and rotation of the paw internally and the tarsus or the calcaneus laterally, and the dog cannot extend completely the stifle cranially, and that's why kind of like midway in the air, that the extension of the limb stops, and then the dog puts the leg down. The movement is very characteristic, it's pathognomonic of gracilis contracture, but sometimes the movement is so quick that you cannot really see it, and that's why I put it in slow motion. So maybe just by seeing this gait, you will remember if you see a dog with gracilis contracture. This is another dog. Let's see if you can see. This is not the most obvious one, but you can see that the dog has a hyperflexion of the tarsus. Now that when the dog turns, it's more obvious. Do you see that there's more hyperflexion in the tarsus in the right side than on the left side? Let's see it again. It's not completely plantigrade, but there's more flexion in the right tarsus than in the left. So that will be possibly consistent with a partial injury to the calcaneus or some type of injury of the common calcaneus tendon. We need to be careful with some neurological conditions. This is not completely pathognomonic, but we will need to check the integrity of the common calcanean tendon. This is a complication of a surgery. This is how pivot shift postoperatively looks in a dog that had a TPLO and has this pivot shift, this excessive instability internally. So it's this weird clocking lateral displacement of the tibia during weight bearing. Do you see? It's very quick, but you can see that in a dog postoperatively after TPLO, the dog shouldn't be doing this. There is a sudden movement of the tibia laterally somehow when the dog bears weight. So this is how pivot shift looks after surgery, which is not normal and it should be managed. This is another dog. Let me explain before. This dog was sent, was referred to the neurology service because the dog was down, and they suspected it could be, IVDD or something like that. But then when you start doing the examination and you put the dog standing and kind of like seeing, you see the dog walking, you can see that it's not very neurological. The dog is just doesn't want to be standing up. But when we start doing some reflexes and postural reflexes, you can see that the dog doesn't look to have any CP deficits. Hopping is doing well. It's just that the dog doesn't want to be standing up. It's kind of like he's walking on eggshells. So this dog had polyarthritis. So once you start doing your orthopedic examination, you can feel joint effusion in multiple joints, especially it's more obvious in the tarsi and the carpi. So just, it's just to show that sometimes things are not like they show. So this dog looked like a neurological case, but it was not, and it's actually a polyarthritis dog. So these are just some of the gait changes that we may see in dogs with orthopedic conditions. And then obviously, after that, we need to do our orthopedic examination. So with our orthopedic examination, we are going to be manipulating and palpating different joints and the bones so we can check how the muscle is, the volume and the tone, see if there is any area that is hot and swollen, areas that are painful. Sometimes these can be challenging, especially if we have an aggressive dog. We may not be able to do a conscious examination. Or if we have a dog that is very stoic, they may not show pain, but we may check other things. We want to check if there's swelling, if there's joint effusion, if there's crepitus in any joint. We always need to check range of motion, if it's increased or decreased, and also if there's any instability. So we need to check all the joints, and we are going to go through them. And hopefully with that, we will be able to localize at least the source of the lameness, so at least the joint that is affected that could be causing the lameness. So for the orthopedic examination, if you've seen my previous webinar, I always do it in two phases. One is with the dog standing and one with the dog in lateral recumbency. But always the orthopedic examination needs to be done in a systematic and ordered way so you don't miss anything and you always explore every single joint and every single part. So you need to explore all four limbs, even if the dog is obviously lame in just one limb. Explore all four limbs because you need to have the big picture of what's going on with that dog. The dog may have, or the cat may have other issues that may change the management options for you. So I usually start with the dog standing up, and then I go with an orthopedic examination in lateral recumbency. I generally leave the most painful, what I think the most painful area would be. I generally start with the distal to proximal. And then, for example, if the dog is lame in the right hind, I leave the right hind limb to the end. So I explore the other three, and then the last one, I go with the one that is probably painful. Otherwise, the dog is going to get very stressed, and you may not be able to finish your examination. Sometimes they are pretty good at telling you where is painful, but sometimes they are not. So you can check, for other reactions, changing in panting, for example, or the pupils. They may dilate in the area that is painful for them, or they may become agitated. So it's not always just seeing that they are painful and they are howling, for example. In some occasions, you may not be able to finish the orthopedic examination and you may need to do it under sedation. You can still get a lot of information. The only thing is you miss the information regarding to pain. But if the area is very painful, even under sedation, they may react anyway. So I start with the animal standing. As I said, I always check the soft tissues. As I said, the joints, the bones. Don't forget the bones, because we may have a dog with panosteitis, for example, and also the limbs for any alignments. Generally, this is quite obvious if there is any deformities, but you may need to put the dog in dorsal recumbency and just check that the legs are aligned. And don't forget to check the iliopsoas. I'm going to show you several videos about checking the iliopsoas, because many times we forget about checking the iliopsoas. So I do with the animal standing. I'm checking ventral to the lumbar vertebrae, which is where the iliopsoas, the muscle belly, is. And they are usually quite painful and they are guarding the area. And then I check, as you can see here, the insertion point at the lesser trochanter of the femur, and they are generally very painful. And then I will do extension of the hip with internal rotation. I will show you this in another video, but generally they are quite painful when they have an iliopsoas strain. So with the animal standing, so I start, as you can see, just checking muscle mass, if there is any asymmetry, sorry. So I generally palpate both hind limbs at the same time. I feel like I can palpate joint effusion better when they are standing. So you can see me palpating joint effusion in the stifles, medial to the patella ligament. And then I check the tarsus also medially and laterally and see if there is effusion. I'm checking for changes in temperature, muscle mass, as I said, always comparing one side to the other. And then since I'm there, I'm checking CPs and see if the proprioception, if there's any neurological deficits. Also, you can check obviously integrity of the tendons, especially the common calcanean tendon. So some changes that you may see with the animal just standing. So for example, on the right, this is a completely plantigrade dog. This dog has a complete rupture, or may have a complete rupture of the common calcanean tendon. It may be also neurological, but that's how it will look if they have a complete injury to the common calcanean tendon. So you may need to check it longitudinally. If it's a chronic injury, you may not feel the gap because there will be fibrous tissue. So you may feel, complete tissue in there. But obviously the neurological examination will also help to differentiate between an orthopedic and a neurological problem. And also generally, even if we don't feel the gap, we may feel inflammation or swelling of the tendon. Here on the left, you can see the left hind limb is normal. The right hind limb, you can see that there's more flexion of the tarsus, and I hope you can appreciate that the toes are kind of like that. They are curled, they are flexed, and this is typical of partial injury to the common calcanean tendon with an intact superficial digital flexor tendon. So the other components of the common calcanean tendon are injured, and that's why there's hyperflexion, but because the superficial digital flexor tendon is intact, there's no complete plantigrade, and that's what's causing the flexion of the digits. So those will be, typical positions that we may see. Also, the opposite, we may see dogs with tarsal hyperextension, which sometimes can be quite dramatic, and it looks like the tarsus is going cranially. This is generally associated with hip dysplasia, because for them it's so painful to extend the hips that they are trying to not extend the hip and just increase the range of motion generally of the limb by extending too much of the tarsus. So generally it's associated with hip dysplasia, canine hip dysplasia. Other abnormal positions that we may see are in the digits. So this is the anatomy of the deep digital flexor tendon that inserts in P3, and the superficial digital flexor tendon inserts in P2. So when we have an injury to the deep digital flexor tendon, this is rupture. So we are going to have the nail going up, which is called knocked up toes. So this is typical. This is what we see in the dog. It's typical for an isolated rupture of the deep digital flexor tendon, generally in 1 or 2 digits. If we have an injury to the superficial digital flexor tendon, which inserts in P2, this tendon, it's keeping that angle between P1 and P2. So when they have this injury, the toe is flat. Instead of having, as you can see in this left, well, this is the forelimb, but it will be the same in the hind limb. Instead of having that normal angulation of the phalanges, the toe is flat. Here in this case, we have 2 toes that are flat. So this is called drop toe, and it's typical of an injury to the superficial digital flexor tendon. And this is another example here in this digit, the first one. If we have an injury of both, we will have both. We will have a nail that is going up, a toe that is going up, and a flat toe. Okay? So those are things that you can see with the dog standing or the cat standing, more common in dogs. We may have a quadriceps contracture, which is very, very obvious, but the time that generally they arrive to the clinic, they are very obvious, this complete contracture and inability to flex the stifle. It looks like a stick, completely straight. So this is how quadriceps contracture looks like, in this case in a cat. So as I said, when we do our orthopedic examination standing, we are going to be checking, as you saw in the video, for joint effusion, mainly in the stifle and the tarsi, stifles and tarsi. You can also check the digits, but it's a little bit more difficult. The hip is very difficult to feel any joint effusion. We will check if there's changes in temperature, changes in body weight, or weight bearing, percentage of weight bearing. And generally, I check the iliopsoas when the animal is standing. So this one, you cannot hear him, but it's very painful when I palpate the iliopsoas. And now I'm going to try to do the extension of the hip with internal rotation, but the dog is extremely painful. And this is what happens. This dog had bilateral iliopsoas strain. I was so painful that I couldn't even do the maneuver to check it. So I tend to do it with the animal standing, but you can also do it with the animal in lateral recumbency, and I'll show you another video in lateral recumbency. I feel that it's easier to palpate joint effusion with the animal standing and also to check for pain. For example, in this dog that had pain, the dog had a tarsal OCD, so it was painful in the left in comparison to the right. So it's not reacting on the right, but it's reacting on the left. A similar reaction we can see when they have injury to the deep digital flexor tendon as well, because it goes in that area. We can have some abnormal positions of the animals. Sorry that this is with the animal inside of the cage, but the dog is sitting in a completely abnormal position. It's kind of like very cranked and sitting almost on the sacral area. This dog had a polyarthritis as well, and it was so painful for him to flex the tarsi and the stifles as well that he was sitting in that position. So some positions like this could be, related to immunomediated polyarthritis or a polyarthritis when they don't want to flex the joints. So in lateral recumbency, and I'm sorry, this is just the forelimbs, but I'm going to show you several videos of doing the orthopedic examination in lateral recumbency. I always do it from distal to proximal, always checking range of motion of the joints, crepital instability, and also I palpate the bones for any pain or instability as well. So I generally start with the digits. You can do it individually or together. I tend to do it individually if the animal allows me to do it to check if there is any crepitus, any instability or swelling of the digits, and I always palpate the metatarsal bones. I'm gonna run that video so you can see that I'm checking the toes, in between the toes as well, because they may have dermatological problems and dermatitis and pododermatitis or a foreign body or a fistulous tract or something, so I always check it. I'm checking there. Generally, if there's swelling, you can feel it quite well. Then you need to check the sesamoid bones, which are caudal to the metacarpophalangeal joints. I'm checking range of motion of the joints, especially the metacarpophalangeal joints. I'm checking the sesamoid bones now, and then I palpate along the metatarsal bones. And then every time that I reach a joint, I check for the normal range of motion, which is this one. And then, well, you can check joint effusion. I feel it better with the animal standing. Then I'm checking the integrity of the calcaneus tendon with a little bit of flexion in the tarsus. And then I always check the collateral ligaments with the tarsus in extension. And then also if there is any instability craniocaudal. So this will be kind of like starting with, and then I continue with the tibia and fibula and see if there's any pain. So changes that we may see is an injury to the common calcanean tendon. Generally, when you extend the stifle, we cannot flex the tarsus that much. So this means that there is an injury to the common calcanean tendon. This is not normal. Okay, this is a cat, this is a dog. Here we have a video. You can compare this is a cat. So this is the normal common calcanean tendon. If we extend the stifle, we cannot flex completely the tarsus. And obviously, you need to palpate the integrity of the common calcanean tendon. And this is the abnormal tendon. You can see that if we extend the stifle, we flex a lot the tarsus, and it's because of the injury of the common calcanean tendon. So quite obvious. Other things that we may see, this is a lateral luxation of the superficial digital flexor tendon. It's not such a common injury, but this is what you will see. Sorry, this is in surgery because we were going to do the surgery and we forgot to make a video before. It's not such a common injury, but hopefully you will see it. So when you do flexion and extension, see that the superficial digital flexor tendon luxates laterally. We cannot see it every time, but here, yeah, you can see it very well in that moment. See, and now we have reduced it, and now we are gonna luxate it again, okay? So this is what you will find with a lateral luxation of the superficial digital flexor tendon, which is not such a common injury as I was saying. We always check for tarsal instability. Many times it's associated with a shearing injury, so injuries to the soft tissues, but you always need to check the stability of the tarsus. In this case, this is a cat. They have more, their joints are more lax, so you always need to compare it to the contralateral side. But here is very obvious that the medial collateral ligament is injured because there's excessive valgus in the tarsus. We are going to compare it to the other tarsus. There's also an injury, but the moment you always need to do it in extension. Let's put it in extension. So it's a cat, so there's a little bit more movement than generally, and that's why you need to compare it. Okay, but here I think it's very obvious the medial instability. But sometimes in cats, it's a little bit, you are not sure because the tarsus is more lax. So always compare it to the other side. And then we continue, we palpate the tibia for any pain, inflammation, instability, and then we get to the stifle. As always, check range of motion, any crepitus, any mediolateral instability, always in extension, and then we need to check for craniocaudal instability. We do the drawer test and the cranial tibial thrust. Okay, so here we have first a video. Oh, sorry, I don't know. Let me stop this one. So this is how we check the stifle. We are checking muscle mass, range of motion. This will be normal range of motion in a dog. Now we do the drawer sign or the drawer test. And my tip for you is try not to include a lot of muscle. So try to put your fingers just behind the femur and the tibia. Don't get too much muscle because then everything is going to move not very well. You are not going to be able to do it very well. So just put your fingers cranial and just caudal to the bone. Sorry. So this is the cranial drawer. So you can see that my thumbs are just behind the femur and the tibia. And then we are going to do the cranial tibial thrust. So I'm holding the femur, putting my index finger from the patella to the tibial tuberosity, and then I flex the tarsus. And if there was a rupture, I will see the tibia moving forward. I'm checking the patella, and I'll show you some photos as well. And then with the stifling extension, I'm checking mediolateral instability as well. Here in this video, we have a dog with instability. So you can see very obvious this is a complete rupture of the cranial cruciate ligament. And then with cranial tibial thrust, we can see that the tibia is moving cranially and hitting my index finger. Oh, so this is, for example, a dog with excessive internal rotation. So the dog has instability. But when we do, so this is the cranial tibial thrust. But then when we do flexion and extension, something a little bit subjective, but we can see that the tibia tends to go medial, as you can see here. So generally, this happens when you have an acute rupture and there's not a lot of fibrosis in the capsule. So you just need to be careful in those cases because if you do a TPLO, that's going to counteract the craniocaudal instability, but not the internal rotation. So if there is a lot, because it's an acute rupture, you may still have too much rotational instability. So in those cases, I tend to put a lateral suture on top of the TPLO, for example. There is a paper that was published a few years ago about checking for pivot shift. It was kind of like a tibial compression pivot shift test. And this is a video. It's just to evaluate for this excessive pivot shift. As you can see, there is a clear, so you apply this external rotation and then you try to do the tibial compression test and there is a clear clock of the tibia going in internal rotation. Meniscal click, hopefully you can see it, but generally there is an obvious clunk when you flex and extend the joint. Hopefully you can see it. So I'm flexing and extending. And here there was kind of like this movement. So this dog had a cranial cruciate ligament rupture with a meniscal injury. And there was this movement that you could feel sometimes, not all the time, here again, when you do some extension. So these are things that we may see in the stifle. We need to check for medial patella luxation. So we do some internal rotation and try to luxate the patella. And we can actually luxate the patella outside. I don't have a video for that, unfortunately. And sometimes we may have a stifle luxation, so injury to several ligaments, like in this case, in this cat. So it looks very unstable mediolaterally and also craniocaudally. So generally, was a cat. Generally, the combination is a cranial and cranial cruciate ligament rupture, many times caudal cruciate ligament rupture, a medial collateral ligament, and also a medial meniscal injury as well. And then we go up, and then we go to the hip, and then we check, as always, range of motion, crepitus, see if the dog is painful. We do abduction, and then we do generally the ortolani test, which it may be positive in puppies and it's generally negative in adult dogs because they have fibrosis in the joint capsule. So it's not typical to find ortolani test. So it's not, we don't generally find the ortolani test. So this is how we explore the stifle. So we palpate the femur. We get to the hip. So I always, just do some movement and see if I feel crepitus, and then I do flexion and extension and see if there's decreased range of motion. Generally will be decreased extension of the animal. And then I'm going to do the ortolani test, which you need to hold your hand on the lumbar area and then do adduction of the limb, pushing the femur proximally, and then do abduction. And the first adduction will subluxate the hip. And then when you do abduction, abduction, then it will stay in place. Okay, you can do also the Barden's test, which is here. You are trying to just lift the femur. And then here, for example, I'm checking some landmarks to see if there's any hip luxation. But I'll show you some pictures. This is normal. This is how a positive ortolani sign looks. So we need to look here and we can see it kind of like a pop. Did you see it? It's very subtle, but you can feel it better than seeing it, but you can feel this clock of reduction of the hip into the acetabulum. This is another dog with a iliopsoas strain. You can see that I'm doing extension and internal rotation of the hip, and the dog starts being quite painful. So depending on the dog, I may need to do it in lateral recumbency. So don't forget to check the iliopsoas. This is a dog with a gracilis muscle, a gracilis contracture, so we cannot completely extend the stifle. So this is typical, together with the typical lameness that we saw before. And if we have a dog with a hip luxation, this is what we will see. Generally, this is how they stand. Non-weight bearing and with external rotation and the leg kind of like towards the midline. And if we put one finger on the wing of the ilium, another finger on the greater trochanter, and another one on the ischiatic tuberosity, they will be in a line. So in a normal animal, this will be normal. This will be the normal position, okay? In the wing of the ilium, greater trochanter, and ischiatic tuberosity, they should form a triangle. So this is the normal hip in this cat. And this is the hip luxation. So the 3 points align, generally because it's a craniodorsal luxation. So you can see that the hip is craniodorsally luxated. So the greater trochanter is luxated, is displaced proximally, so it forms a line with the other landmarks. In other considerations, you can check the joint range of motion with a goniometer, so you have kind of like an objective measurement. You can also measure the muscle mass, like the circumference, with a tape or a Gulick tape, so that you can, check the progression of the animal. If you suspect that there could be a neurological component, you always need to do a neurological examination. And then just remember that cats, the gait analysis and orthopedic examination may be more challenging, so they don't like walking around. You can see that this cat is kind of like walking a little bit curled like that or crunched. This dog had bilateral patellar luxation. But they are not the easiest patients to explore, and also because they have lax joints. So sometimes it's a little bit difficult. So always check with the contralateral limb. And hopefully with this, you will be able to localize where the problem is, at least the bone or the joint where the problem is. So don't forget to check for joint effusion, pain, crepitus, instability, all these little signs. And once you've localized the problem, then you can do more diagnostics. You can start with diagnostic imaging, radiographs, or CT. You may need to do joint fluid analysis or blood work, depending on your differential diagnosis, serology, or other tests. So hopefully you will be able to localize where the problem is. So take-home messages, and with this I finish. Gait analysis is very helpful and is actually essential, and sometimes it can prove diagnostic with some conditions. Don't forget to perform a complete orthopedic examination in all 4 limbs in a systematic manner so that you don't forget any parts. Pay attention as well to posture, joint changes that you may see, and instability, because they can give you clues as well. And also remember that cats have more elastic joints. So thank you very much for coming. I will be happy to answer any questions that you may have.
Thanks so much, Pilar. That was great. Really informative for me, especially because my dog's going Well, she's actually got an open teleconsult with you at the minute that you've been commenting on, so that was quite informative for me.
Okay.
Um, we do actually have a few questions that have come in, so I'll crack on and ask them to you if that's okay.
Yeah, that's fine.
Um, so the first one here from Nectarios is could endocrino endocrinopathies, that was a very large word for me to say, sorry, like Addison's cause hind limb lameness?
Some endocrinopathies could cause lameness and especially posture changes. Especially, I would say more Cushing's, for example, could lead to lax tendons, and you can even see animals that are plantigrade. Addison disease, I guess, could cause some changes in collagen, but it's not that typical. It will be more typical, the collagen changes for Cushing's or hypothyroidism. Um, but is not that typical specifically for Addison's. But depending on what I see, you start with some blood work and you may see some changes. But I would say more, I would say Cushing's, hypothyroidism, some changes in limb positions in puppies. These flexural deformities are associated with this flexion of the carpus, sometimes plantigradisms in puppies, which is self-resolving most of the time. So yes, some endocrinopathies can cause lameness and posture and changes in the joints. Yes.
Awesome. Next question would be, in cases of subtle or shifting lameness, what are your go-to strategies for distinguishing between stifle, hip, and lumbosacral sources, particularly in large breed dogs?
So the orthopedic examination is going to be essential because there are some conditions that may show a lameness that is very, very similar, or even some clinical findings that are very, very similar. So, for example, an animal with hip dysplasia, lumbosacral disease, or even iliopsoas strain is going to be painful on extension of the hips. So, you may see a dog that is painful on extension of the hips. So, you may need to try to isolate and see, okay, is just the hips, or I need to press the lumbosacral area and see if that's painful. Also check the iliopsoas. Obviously, if you have pain in that area on extension of the hips, I will start with some radiographs or even a CT of all the lumbosacral area. You will see if there are changes in the hip or the lumbosacral area, and then you will need to try to isolate and see if you can um, um, generally you extend the hips and then press on the lumbosacral area, and generally they are very painful when they have lumbosacral disease, and sometimes they can have neurological deficits. I would say, for example, if I have a dog that has changes in the stifle and changes in the hip, and I see radiographically changes in the stifle and changes in the hip, most of the time I will address the stifle first than the hip. That will be most of the time, because generally, especially depending on, I mean, obviously the type of lameness is going to be very helpful, because generally with the stifle disease, the lameness is going to be mainly unilateral. Obviously, we can have a dog with bilateral hip dysplasia and bilateral cruciate disease, but hopefully you can have a unilateral cruciate disease. So generally, if it's unilateral, it's more likely to be the stifle than the hip. But also, the degree of pain can also give you clues if it's more painful in the stifle or more painful in the hips. But I would say most of the time we address the stifle first. In other joints in the forelimbs, I may use local anesthetics to differentiate between elbow and shoulder disease. In the hind limbs, it's a little bit trickier because you have not only the inflammatory component, but also the instability component. So if you block the stifle, for example, the lameness may improve, but because there's instability involved, that improvement may not be that obvious. So I don't frequently use, or I don't usually use blocks in the stifle and hips. I go with the type of gait, my findings. Also, most of the time, the stifle takes priority over the hip. But there's the odd case where the hip is really, really, really painful. then I may address the hip first. But I would say that most of the time it's first the stifle and then the hip. Sorry, I talked too
No,
much.
that was great. That was great. Thank you. We've got another question here from Pia. Is pivot shift a common problem after TPLO?
It's not that common, but it's been reported. So it's only a small percentage of, I don't remember the number at the moment, but it's a small percentage of dogs may have pivot shift post-operatively. Lucky for us, it's not, it's a low percentage, but you need to suspect of a pivot shift in a dog that has had TPLO and is not doing well post-operatively. Obviously, you need to the gait analysis is going to be very useful and also orthopedic examination. But generally, we rule out other conditions. So, for example, we generally start with radiographs to make sure that all the implants are intact in an animal that is not doing well after TPLO. Depending on what we find, we may tap the joint to know if there is an inflammatory component like a septic arthritis. Sometimes it can be a high-grade septic arthritis and they are very, very lame. The joint is very swollen, very painful, but sometimes they can have a low-grade lameness, a low-grade infection that will lead to a lameness that is kind of like there all the time. But obviously, our orthopedic examination and the gait will give us a lot of clues about if we have pivot shift, which will need to be addressed. But lucky for us, it's not that common.
Cool, thank you. The next question would be, how do you incorporate diagnostic tools such as gait analysis, nerve blocks, or imaging when clinical examination findings are equivocal? I feel like.
Yeah, it's kind of like this. I mean, gait analysis is very important. I'm lucky because I have a pressure mat. So we tend to, at least every dog that goes to surgery, we tend to do the objective gait analysis. We put them through the pressure mat. But I especially use it in those cases where lameness is very subtle, or I want to evaluate how the animal progresses after surgery in an objective way. So in those cases, I will do the pressure mat. So for example, in an animal, I showed you, well, dogs with iliopsoas strain, sometimes the lameness is not very marked, especially working or competition dogs. The lameness is not very obvious. So the objective gait analysis or the pressure mat can help you seeing that decrease pressure on that limb. Other diagnostic techniques that I may use are the intra-articular blocks that I mentioned, so injection of local anesthetics in the joints, mainly in the forelimbs, but it could be helpful in some cases in the hind limbs. And then diagnostic imaging, sometimes I go directly with the CT. If I suspect that I have like an OCD in the tarsus, for example, I will go with the CT. If I suspect that there's lumbosacral disease, I will go with the CT because you can see things much better. I'm more used to doing radiographs and evaluating radiographs for hip dysplasia and cruciate, but I understand that nowadays we tend to do CT even more than before. But I'm more used to looking at hip dysplasia and stifles with the radiographs. But we have a lot of diagnostic options that can help us.
Lovely. And then we've got one more question here. Are there specific gait patterns or postural signs that you find particularly pathognomonic? I don't know if I've said that correctly, sorry, for
Yes.
certain hind limb conditions, and are they breed dependent?
Yes, I showed you the gracilis contracture, that movement of the tarsus. I call it the Michael Jackson kick because it's very similar to the Michael Jackson kick, actually. And that's pretty much pathognomonic for gracilis contracture. Other lameness, other types of gaits or other types of lameness can make me very suspicious of a specific disorder like the skipping lameness with patella luxation. But in some occasions, so that will be the first thing that I would rule out. But in some occasions, I've seen that dogs with a nerve root or a nerve root lumbosacral disease in that area, or iliopsoas strain because they are painful when extending the hip. They may show a lameness, very kind of like a skipping lameness because they don't want to extend the limb. Or some dogs with some dyskinesias can show this skipping lameness, but that's very uncommon. My first thought will be, for example, the medial patellar luxation. Other pathognomonic, well, the plantigrade stands, but we will need to rule out a neurological condition, for example, or diabetes, which is related to a neuropathy in cats with diabetes. They can also be plantigrade in the hind limbs. So some of them are quite clear associated with a disease. Oh, I didn't mention the gracilis contracture is typical for German Shepherd dogs, specifically police dogs, but working dogs in general. So yeah, it can be quite helpful evaluating the gait.
Amazing. I think that brings us to the end. I think, have you got the last slide there, by any chance?
Yes.
Yeah. Um,
Uh,
so just for to wrap things up, we do have some more webinars coming up over the next few weeks. If you'd like to know more about them, you could just scan the QR code below. Um, Also, if you'd like to learn more about how our team can support you and your team with our services, just give us a shout on the email address below for a no obligation discovery call. Thank you all for tuning in and have a good evening. Thank you,
Thank you very
Pilar.
much, everyone. Thank you, Banu.
Thanks. Bye.
Bye.